And today we're going to talk about ACDFs, or otherwise defined as anterior cervical discectomy and fusion. Dr. Dick, why don't you explain what's involved in performing these procedures, a little bit about what types of symptoms they address as well.
A patient with who needs anterior cervical discectomy and fusion typically presents with neck pain and arm pain, neck, shoulder, and arm pain, variable amounts of those. It's typically related to a disc herniation, a soft disc herniation, or sometimes to bone spurs that form and put pressure on the nerve. The arm symptoms are radicular in nature, meaning that they follow the pattern of a particular nerve, and sometimes the patient will have some weakness in the distribution of that nerve. When they don't respond to conservative treatments, physical therapy, cortisone shots, things like that, then surgery is an option. There are two ways to treat those radicular symptoms, one being a posterior procedure where you do a foraminotomy and a discectomy. Typically that seems to work best when they have a majority of arm symptoms and the disc or bone spurs are out laterally. You can get access to them. In a situation where there's predominantly neck or shoulder pain and the herniation or the bone spurs are under the spinal cord, then it's better to go anteriorly and you can do a better job of the decompression from the front, but then you need to fuse the segment. This is the BAKC implant. I think there's that's made by Zimmer. I think there are some other companies who make this implant as well, it's a threaded titanium screw that you do your discectomy and decompress the nerve, and then typically there'll be some bone spurs. You can gather up some bone while you do the procedure. When you're burring down the uncovertebral spurs or the spurs that are back pinching against the nerve, you save all of that bone and use it for bone graft. Also, when you put the cage in place, you ream out a little space for it in the vertebra above and below, and there's bone from that reaming that you put inside the cage. This works by in immobilizing the level by causing stretching in the ligaments around the front and the side and back of the disc, and so it holds it nice and firmly. And then you fill the cage with the patient's own bone, and then that heals across, fusing the two vertebrae. I like it because there's no profile, there's no plate under the esophagus. You can use the patient's own bone without going to their hip to harvest it. I think with appropriate patient selection, again, this is a very safe procedure as an outpatient.